Good afternoon, Mr. Bryan.
Hello.
Oh, very good cup.
Yeah.
I like that.
The secretaries gave it to me. Very flattering. I'm not sure why I've got that background on. It's completely random. Oh well.
It's quite lively, though.
Yeah, we'll get rid of that later. Do you want me to send the slide stuff? Do you need to keep it on the record for you? Or are you just recording it?
No, I don't. I'm not sure. Stacey maybe will. We'll see. You can send it to me though. It'll be helpful.
It'll probably be sensible. Multitasking. It's always good.
Yeah.
And Geeta's here as well.
I am.
Marvellous. And how is the vasectomy? I heard vasectomy is going very well. You're doing other people's.
How are you, Nick?
You do. I'm fine.
Where you, Alice, and I take a sort of review as scouts the history of hairdos in Iceland. I was guest host, of course, yeah. And finally, Lancashire. This is where we go along Lancashire and drivers all time and Carolina using the sting and the big engine. Yeah. The right of police crew. No, I have funny enough. Yeah, I have to go and do big main control what they call traffic.
You got the first.
Yeah. We're not at past yet, are we? So we better.
About 30 seconds, I think.
Muted, aren't I? Do you want to leave it till 12:32 and then start, Nick?
Yeah, I'll give it another couple of minutes of this. So desperately finishing things off and tidying up.
Are you still working on it?
Yeah, 5 minutes ago. No, of course not. That was at midnight last night. Shall I begin? I think it'd be good, wouldn't it? I'll start. Okay. So we'll try and have a nice, concise and accurate talk, unlike the present interviewees and talkers that we seem to be getting on TV at the moment. So I shall see if I can share my screen first and begin the talk. Here we go. Let's see if I can get this working. Oh, can anybody see slides? Can anybody see anything? Can't see anything.
Not yet. Did you click the share at the top?
I
next to the
have.
leave button.
And it's not behaving.
You got more than one screen?
Nope.
Hmm.
Show video in real time. Maybe that's what it wants.
Now we're looking at you.
That's even worse, probably. No good there. No slides. Nope. That's definitely not what we're wanting then.
You should just be able to click share screen and then, or
That's
share
what
window.
I'm trying to do, yeah.
There, we've got your screen now, so we can
Got a
see
screen.
your calendar.
Is
there we
that
go.
better? There
Yes.
we go. Good, to give me too many choices. Never a good idea. Marvellous. Well, we shall start then. So we're going to talk about benign prostatic hyperplasia and male low urinary tract symptoms, etc. And obviously, please, interactive as possible. Those who want to say, please put a hand up or ask questions as we go along, please say. And we'll try and make it like that. So first, I was going to talk about just going back to some of the basics, some of the science, the anatomy, physiology. So just the simple questions, and funny enough, what does the bladder do? We've always got to remember that actually the bladder is fundamentally a big floppy bag, 99% of the time. And then just for that 1% when you're actually trying to urinate, it's suddenly contracting. It's literally doing the opposite. It's suddenly squeezing. Obviously, on the other side, what's the sphincters and the pelvic floor doing? Well, most of the time they've got a little bit of tone. They're keeping things closed. And then just for that small time when you're passing urine, the pelvic floor is relaxing, allowing things out. And in between, we've got the prostate. And what does that do? Well, that's a common question from patients. Usually the answer is, well, once you've had your kids, of course, it's not doing anything because it's mainly providing nutrients, antibodies, etc., for the sperm. So after that, as it gets bigger, it causes trouble. And there on the diagram, you can see the various receptors that are relevant. So there's the M3 for the anticholinergics, the B3s for mirabegron, and then down in the sphincter, and more importantly, the bladder neck, you've got the alpha blockers. So that's all, of course, integrated and worked by a whole load of reflexes, which are all trying to talk to each other. And obviously things aren't working so well, not talking to each other very well. But literally that is how it flips from one side to another. This whole system is effectively separate, but is controlled from above by the various reflexes that come down from the brain when messages. And effectively, I always like this slide because it summarizes the whole of how the urinary system's working. Most of the time it's storage. Bladder's relaxed, pelvic floor's tight. And then when you're avoiding it, flips the other way and everything's coordinated. So the bladder's contracting, the pelvic floor is relaxing, and then it goes back to its previous state in storage. So conceptually, that's the easiest way to think about the whole system before you start thinking, well, how can things go wrong or be troubled? And the first thing relative to this is when the prostate is enlarging and causing problems. mainly to the outflow. In other words, it's causing resistance. How does it cause resistance, therefore cause trouble? Well, the system is built, like most of our bodily fluids when they're moving around, it all relies on laminar flow. And so in other words, laminar flow is very little resistance. You can increase the flow very easily with no change in resistance. The problem starts as soon as you get turbulent flow, like the eddies and whirlpools in a river. So as soon as you get that, which obviously if you're distorting the flow, if the prostate's getting bigger, that's a lot of what happens. Then the resistance to flow increases massively. And a lot of that is what is responsible for problems in outflow. It's, funnily enough, I'll go back to that. It's not so much, people don't complain, of course, about the flow symptoms. It tends to be the secondary effects leading to when the bladder is upset with the storage symptoms. That's when people start complaining, generally speaking. So enlargement of the prostate affects the flow, and that's why you get trouble. So that's how frequent it is. Fundamentally, that slide's showing that the bigger the prostate, the more symptoms you're likely to get, but it's not an absolute. So, and this tends to progress as we get older, as men get older. So this is way back from the original Olmsted study, where they literally followed cohorts of people and then started them on finasteride, or in this case, not. And they just showed over 4 years symptoms seem to deteriorate when you have an enlarging prostate. These days, we don't think about that, but it's fairly clear. You can get an idea of how big the prostate is either from feeling it, clearly. Age is relevant. The PSA can be quite useful in that the PSA over about 1.5 tends to indicate a significantly enlarged prostate. It's a slight surrogate for the size of the prostate. And obviously, if the worse the symptoms, in other words, the worse the starting point, the more likely your things are going to deteriorate faster and lead to potential risks of things like tension, infections, or significant problems. So just a quick sort of summary of what we're leading to with symptom assessments. So your flow symptoms, or avoiding symptoms are slow flow, the hesitancy, the difficulty in starting. And then on the back of that, there's can be some dribbling afterwards, and incomplete emptying, that feeling of not emptying completely. Very difficult to quantify sometimes for patients. On the other side, the more troublesome ones are the storage, particularly frequency. Nocturia is part of that, is the worst of all for most people. And then as a secondary effect, the urgency, and even worse than that, incontinence. Like that's the bad bit. Now, I'll go back to that bit before. And so the storage symptoms, although we're talking about outflow obstruction, the thing to remember is that as a secondary effect, when the bladder is having to squeeze harder, when it's having to generate more power to compensate for the resistance in flow, two things tend to happen. The bladder muscle tends to hypertrophy, and it also tends to adapt to maintain its power, its ability to squeeze. And the consequence of that is that the bladder works at smaller volumes. So the functional capacity of the bladder effectively shrinks. So rather than being able to hold 300 mils comfortably, it starts to go down to 200 mils before it starts saying it's very full. Consequently, patients void more frequently. So, having done that, obviously when the patient arrives, how are you going to assess things? I think this is very standard now. It's obviously nice guidance. The useful thing, apart from obviously the history, examining clearly to find out there's no surprises like stenosis and meatal stenosis or a pinhole phimosis of the foreskin, which you do surprise oneself. Very occasionally you get them, and then one feels foolish later on, but it does happen. So it's always worth checking, and of course examining to check the prostate to assess the size. As part of that, I would tend to recommend, because you can easily print these off, is getting the patient to an IPSS score, which has the full 7 questions plus, which is not on this example, but is a full quality of life question as well, which is actually is very useful indicators. So you've got the symptoms, and some people just rate everything is terrible, even because they don't read the questions, and they put 5s across. But then the fun, you may well get a patient who then goes and puts a quality of life score as a 2, as in they're not particularly troubled by it. So you can get these incongruities which you have to watch out for. As well as that, I would, if you can get it done, a frequency volume chart. It does clarify things a lot. You do get the surprises of the patients who say I'm voiding every hour, and then it just turns out the total volume they've voided is about 3.5 litres or 4 litres in a day. Of course, they're going to void frequently. So you do get surprises like that, and it's well worth doing it. That's the formal IPSS with quality of life questionnaire from Baus, and can print those off and use them any time, of course. And frequency volume chart, it's always difficult for a patient to walk around with a jug in their bag or whatever, but it is useful to have. I would recommend. I think this is one of the most useful things NICE has ever produced or printed, because it gives you such a nice guesstimate of how big the prostate is related to everyday object. I say that every day, maybe not for everybody, but objects we can relate to at least. And that way you can get an idea of therefore how likely they are to have a problem. A few little caveats to that is it's very easy when the prostate's actually very small, and we get this particularly obviously in the younger patients. Actually, when you feel the prostate and you feel it anteriorly and you're trying to feel the prostate, you feel this really hard thing. With a prostate that's almost not enlarged, you can actually, and I've done it myself initially, you feel the pubic bone in front and you think, why, that's a really hard abnormal prostate, until you realize what you're actually feeling. So just a little thing to be aware of. And equally, the very large prostate that's so big, it just takes up the whole space, and it's very difficult to tell that there's anything there, except that your finger's distorted and pushed to one side, pushed backwards. So anything above 33 cc's is technically an enlarged prostate. Now, having said that, is there anybody, I haven't got this far, anybody want to ask any questions? Because there's no hands up yet. But otherwise, I shall carry on. So, investigations for BPH. Well, they're all the things we're familiar with. NICE guidance always include. PSA is always a difficult one, but I think it is quite useful because of the surrogacy for the size of the prostate. And we are encouraged to do that anyway. Of course, include the HbA1c for the occult diabetics, who may well have low urinary symptoms as well. And if you're concerned, particularly obviously hematuria or anything else, or you think that the patient is leaving significant residuals, then an ultrasound is very useful. If you have access to a flow machine as well, even better. But I appreciate that's not recommended for primary care. NICE guidance anyway. But if you do a flow test, then those who go back to their study days years ago may remember that number 1 is normal flow shape. Number 2 is starting to get a little bit more obstructed. Number 3, that's actually a fairly classic stricture or very obstructed flow. So now we get on to the things to do with treatment. So how are we going to treat the people with enlarged prostate and their symptoms? I would include conservative management, which is often forgotten because it actually involves quite a lot of time, of course, to explain to the patient, if they're not doing it already, which many are, to cut out fluids, particularly before they're going to bed, if they're going away or on traveling and get themselves a bit dry. I would recommend pelvic floor exercises. It's no bad thing, particularly those who are getting more urgency. It can help calm the bladder and behave better. It helps coordinate things, and I'm quite a fan of it. Explain it to the patient because it often helps that they understand how it's all working, because they'll confuse prostate cancer with enlarged prostate. And then there's the medications. I put antibiotics at the bottom because if they've got infections, obviously an antibiotic. But if they're getting regular infections, they are likely to be heading towards surgery, because that's one of the cardinal indicators for surgery to open up the prostate. And as you're all familiar with, the tamsulosin and finasteride, and for those with marked urgency, anticholinergics and or mirabegron. And just to dispel the myth, anticholinergics are always said, and on the, of course, the piece of paper that comes with the medications warns against the risk of going into retention. However, there have been papers and research that shows actually it's a myth. Those who go into retention were going to go into retention anyway, or are in retention, and the anticholinergic has not made them go into retention. They just have severe symptoms. So just to be aware of that. And then, of course, so education, pelvic floor exercises, all the straightforward things for patients to do themselves may well be enough. But then the medications, there's the alpha blockers, the tamsulosin, or alfuzosin-zatrol, should you wish. And that's blocking the alpha receptors in the urinary tract, quite targeted to that area, very relatively few side effects, except the common one of bladder neck relaxation, and most men get retrograde ejaculation and a dry ejaculate. The finasterides or dutasteride, should you wish, probably no difference between the two. That's going to shrink the prostate by blocking the 5-alpha reductase, making testosterone convert to dihydrotestosterone within the prostate, stimulating the prostate and tending to cause enlargement in the long run. So you're blocking that, making the prostate shrink gradually. It really isn't very quick. 3 to 4 months for starting to get some effect, 6 to 12 months for its full effect. Whereas the tamsulosin, the alpha blockers, will have some action pretty quickly. Within a few days, the patient will probably notice. There is, of course, the evidence that we know of that the combination for an enlarged prostate above 30 cc's is better than one or other of the medications for tamsulosin finasteride on their own. So you need to go through the side effects and discuss with the patient. But if they've got an enlarged prostate with outflow symptoms, then the two together are best. And that's the same also the quality of life score. And that's this last slide here. And increasingly, and we're trying to develop this locally with everybody, so we can have a low urinary tract symptoms pathway with a one-stop clinic at our end to try and make things work better for everybody. I'll just put that up, not to look at, but just to say that watch this space. We will be trying to talk to everybody in the near future and engage with the IPG for this and everybody else. So when these things are not working, when all the conservative management medications are not working, of course, being sent or referred in for ourselves, we of course will tend then to do the flow test and a chart. Ultrasound scans as required, and flexible cystoscopy if it's more complex. There's a concern about irritative symptoms at all, any sign of blood, and for that matter, more mixed symptoms, because the flexible cystoscopy increasingly will then help guide us considerably on the right surgical management, which is hopefully when people come to us, to the secondary care, that is what they're heading for. So what do we have here locally to offer? There, of course, is the good old TURP, and there are possibly we're going to try to do HOLEP soon. Aquablation, well, who knows? If royalty can have it, so can we. Hopefully, but as well as that, there's the minimally invasive surgical techniques, which we do Urolift here, which we can do under local anaesthetic, to try and open up the prostate. So there's the resecting surgery, that's TOPs, the HOLEPs, and then there's opening up the prostate with Urolift, all the others like Resume and Itind, and we shall go through those to familiarise everybody. So the three minimally invasive treatments around now, all recognised by, I think, NICE. Certainly Urolift and Resume and Itind, and there's going to be some trials, I think, to try and compare them, but that's going to take some time. But just so that people can be aware of what this is, what these are. So Urolift, personally I find it excellent, and effectively you're putting these implants. If you look at the bottom left, that's what an implant looks at like when it's been created, obviously within the prostate, and you can see the 4 pictures on the right. Effectively, this is what's going on. You're compressing the walls of the prostate across, firing this implant across, which anchors itself on the outside of the prostate, and then you apply another anchor on the inside, and that keeps the walls of the prostate open, and it works well. This is our local outcomes compared to the standard, which seems to show that we're doing the right thing, and it certainly works. The key thing with all of this is selecting the right patient. And in all of the minimally invasive surgeries, the key things to remember is that the prostate can't be too big, broadly 60 cc's in reality. It's thought to be 80 cc's, but 60 I think is the upper limit. Not having any significant median lobe, any large amounts enlarging into the back of the bladder there, and ideally probably not a very high bladder neck. In other words, a big chunky bladder neck with muscle there. That's probably more the preserve of the Itind operation. But otherwise, these work well for the smaller prostates, extremely well, and all can be done under local. So this is the Resume machine. Again, can be done under local anaesthetic. The problem is that if people tend to go home with a catheter, it causes quite a lot of irritation for some months. But basically it's injecting steam into the prostate tissue to make it shrivel and shrink and open up the prostate that way. There is now a small study which is going to carry on called the CLEAR study, which does show actually Urolift ultimately is equivalent to Resume or vice versa, but with the Resume they get a lot of this irritation and some more side effects initially in the first 3-month period, which tends to make me go against it, the Resume, but that's a personal thing. Then there's a third option, which is this Itind, which is basically putting a metal frame in, and for about 10 days usually, and that literally forces open the bladder neck in particular and part of the prostate and compresses it, and then it's taken out and it leaves things more open. That's the idea, but as you can see from where it's positioned, particularly works on the bladder neck. The final advantage of all these minimally invasive is it tends to cause less side effects for sexual function, particularly retrograde ejaculation. It minimizes that risk, whereas obviously any resecting operations, laser, TOP, they will cut the bladder neck and lead to retrograde ejaculation. So particularly also for the younger patient, younger male, it might have advantages. And there I shall finish. I hope that was a satisfactory run through. Mainly because I just wanted to let people have plenty of chance to ask any questions. Clinical scenarios or anything else?
Can I ask a question, Nick? One thing was about the flow chart. I couldn't read it very well. Got older now, can't even with my glasses. Could you share that if that's okay? And did you say it's a local flow chart that you've developed?
No,
Is that nice? I couldn't quite tell.
You mean the frequency volume chart?
No, the flow chart, treatment flow chart.
Oh, the treatment flow chart. Yes, sorry, the whole thing. The patient pathway that we're developing.
Patient pathway. Sorry. Yeah,
so yes,
yeah.
we're trying to roll that out soon. We're sort of various guys linked to the IPG. We're trying to sort of get it checked and clarified and authorized. But the idea is basically what we've just been talking about now,
Yeah.
to try and have all that lined up so that we're all talking, saying the same thing. And so that ideally you guys have had a chance to sort of do all the first treatment. And if it's not enough,
trial the treatment before they come into hospital.
they're coming straight in. In the same way, it's a bit like you have a fast track referral. We'll have a specific form, you can fill in the bits, send it in, and we just take them in for ideally for a one-stop clinic at this end.
Right, okay, I didn't know if that was already in place. That's why I asked it.
No.
I don't think I've seen it. So.
Yes, it's like everything. We thought it would take only a few months, but no, it's moving slowly. Partly at our end, I have to say, but it will be coming, and we'll be trying to roll it out so that everybody's got that information.
And on that, does it have timelines of like 3 to 6 months of treatment before we try the next thing and the next thing? Does it have those kind of timelines on it, or is it just the patient pathway?
It's not really got those timelines specifically put in there, but you have a point, and I think we probably should try and do a little bit of that. I mean,
because there's no point in doing it for a month, is there? Really, when you try something, it needs.
If you're trying the finasteride, if you're trying the finasteride, you're going to need to give it certainly for 3 or 4 months, probably 6 months.
Yeah.
To make sure it's working. Having said that, obviously, if their symptoms are more severe, chances are it's not going to really help anyway, although you might start them anyway. But yes, it's a little bit, that's the difficulty of putting the timelines, because I don't want to make it too rigid for everybody. Just how it must be 6 months, I don't know, because
at least an indication. I just wondered if there was an indication of timelines on that, really.
No, but no, at the moment, no. I think there probably will be a little bit more, but otherwise you basically hit the exact timeline anyway. What you just said is pretty much it.
Yeah, no, that's fine. And I had a couple of other questions. Sorry if anybody has any other questions. And is it still that if they're okay on 2 lots of medications, tamsulosin and finasteride, which we tend to use quite a lot, that we do their PSAs, but we really have to be mindful of the PSAs? Is that still, because they still might be partly symptomatic, they might be better, so they don't want referral, but we're going to keep them on for years on this because they feel okay on it?
Yeah, you stop it and it'll come off. Yeah, if you stop the tablets, they probably will regress.
Yeah, but what about PSAs?
But the PSA is an interesting one in that there's now, and I think it was from the MTOPS study to do originally with finasteride, even sort of late research. Basically, they show that if the PSA comes down, whatever it reduces by, and broadly speaking stays at that level, apart from a slight drift, that's good reassurance that there's nothing significant within the prostate, as in a Gleason 7 or higher.
Yeah.
So in a funny way, particularly if they're sort of higher PSAs or borderline or things like that, it is quite good extra reassurance. And certainly for those who at our end, if we're not so keen on biopsying them for whatever, might well use that. Or if they've had a negative biopsy but still worried, might well use that finasteride as an extra monitor. So it is quite a useful trick and reassurance. But I wouldn't be doing you might not be doing the PSA more than every year. I wouldn't do it more than that.
Not more than a year, but even then, it's not something you have to do, is it really? But I'm just asking if that's good practice.
You might want to do it occasionally, as you say. I wouldn't be doing it every time. No. But it's good practice to keep an eye on it.
Right. And last question was about the Urolift, really. How long do you find that it lasts? Is it kind of, it's not as permanent as obviously as a TURP, but how long are you finding that patients get?
For those who are happy and it works with, it seems to be, well, our experience is only a few years, but for those it does work, they seem to be okay with it, and the deterioration doesn't seem to be much different from the studies, that different to TURPs themselves. So there's still about the 2% a year, well, maybe a bit more than that, 4% a year reoperation rate. Obviously, again, the TURP, we've got sort of 40, 50 years of experience of it. So any of these other things are, we're sort of 5 or 10 years at best. But that seems to be the figures. Obviously, there's some at the beginning who just aren't happy with it, and that's fine, and then they can still go on to other things should they want it. That's the other good thing about the BISTs, they don't get in the way.
That's all I had.
That's
and
great.
robotic surgery going okay? Robotics?
At our end, Oh yeah, incidentally, yeah. We are actually doing robotic nephrectomies. Obviously, the bowel surgeons are doing all their robotic stuff, and it seems to be going very well. Yeah, I mean, it's a different robot to the one that everybody knows about, the Da Vinci, but it works extremely well and just as the same as the other ones. So yeah.
I went off pace then, not letting anyone else ask questions.
You can ask anyone, apart from who's going to win the election, which we all know anyway.
Maybe stick to football.
Oh no, I'm not going. I have no idea about that. Flipping heck.
Starts tonight, Nick. How can you not know?
Well, sadly, I have a fairly good idea what the result's going to be tonight as well. I suspect.
Anybody else got
Anything
any
else? Anybody else?
questions?
I mean, things for the future. I mean, well, the other thing is, I suppose we've got the minimally invasives like the, say, Urolifts and things, which are very good. I think is a good move forward. The other ones is obviously on the other end of the spectrum, the very big prostates. HOLEP's coming in. I mean, we can actually do very big, well, I can do very big prostates with a TURP. But there's also this aquablation, which is an interesting one. And I think it's got a little bit of more of a stir in the urological community because there's rumours that King Charles had it, but nobody actually knows for sure. It may be something that's coming in, but it's again quite a big, expensive thing that's coming in. So it's basically just literally using a water jet like you do on the patio outside and just blasting the cells away. So it might happen, but at the moment it's just going to be TURPs and some sort of laser HOLEP.
Nice.
Brilliant. Thank you very much for hosting, Nick. I know we organised, but obviously you hosted that there really well, so appreciate your time.
Well, I just wanted to keep it concise as many, if you wanted to ask questions, things, that's absolutely I think more important.
Yeah. Thank you.
Good. Thanks, everyone.
Thank you.
Marvellous.
Good one.
All right.
Cheerio.
Take care.
Bye-bye.
Bye-bye.
Cheers. Bye.